Good evening once again.
Good evening, Doc.
Good evening, Doc.
Okay, so today we are looking at conjunctivitis. And it is going to be one of the most common conditions that we are going to be seeing in regards to the eye. And I'm sure, as you're all aware by now, whenever you hear the itis word, it's likely referring to inflammation of a structure. So this case is not different. It's inflammation of the conjunctiva. Okay. So basically, we want to be able to classify what conjunctivitis is, describe some of the clinical features, and be able to manage them. So this is a brief outline of what we'll be going through. Okay, so as I already said, definition is an inflammation of the conjunctiva, and it's typically characterized by vascular dilatation, cellular infiltration, and exudation. And these features here are classical features of acute inflammation. All right, so you have vascular dilation, which is responsible for the redness that we see. And then a cellular infiltration is where you have the inflammatory cells like the neutrophils moving in. And then exudation is where you're having much of the components of the plasma moving in. All right. As for the anatomy of the spend more time, but as we said the last time, the conjunctiva is made up of two main tissues. The stroma is more of the vascular aspect, and it's more involved in the inflammatory process. All right. Okay. So okay, so this is just still more on the anatomy. As we mentioned, the conjunctiva has the palpebral aspect, which is underlining the eyelids, the fornix that is in the corners, and then the bulba, which is covering, that is the eyeball itself. And the epithelial tissue here is that the part that underlines the eyelids made up of stratified cuboidal epithelium, whereas the phoenicia areas are made up more of the columnar epithelium, and the bulbar conjunctiva has the squamous epithelium. And this conjunctiva, or this mucous membrane, is non-keratinized, and we already mentioned that there are some goblet cells that contribute to the secretions or the tear that lines the eye, or make sure the eye is moist. And as I said earlier, the stroma is a connective tissue that contains the blood vessels and much of the glands. All right. So all of these cells, we mentioned them. I think this will be the third time we are talking about. All right. So to the substance of the matter, we will classify the etiology of conjunctivitis into three main areas. We are looking at the infective causes, that is bacteria, viruses, and chlamydia. Then we also have the allergic causes, then the chemical or toxic causes. So if you ask to classify the etiology of conjunctivitis, basically this is what it is. So we'll start off with the bacterial causes or bacterial conjunctivitis. Now, the main offending agents here are Staph aureus, Streptococcus species, Neisseria gonorrhea, and Haemophilus influenza. Clinical features here are the person presents with redness, and there's grittiness. The grittiness is more like they'll complain of, is like there's sand on the eye. That's the gritty sensation that they'll have. And they might come complain of burning, the eyes, and also eye discharge. Now, when you examine the eye, by way of looking out for signs, you would find that the eyelids are crusted. You'd see crusted, dried discharge on the eyes, so especially on the eyelids and on the eyelashes. And the eyelid itself might look a bit edematous. And the discharge for bacterial conjunctivitis is usually purulent. Though in this modern era, you'd hardly find someone who would have frank pus coming from the eye, but just that the discharge is just a bit more thicker than the usual tears that we have from the eyes. Okay. Then when you unfold or invert the eyelids, you'd see injection, or what we describe as bloodshot. All right, the vessels will be more dilated, and so there's more blood in there, and it will appear more reddened than usual. That is maximal in the fornix. Okay, so if you are investigating this, what you do is a good history of the symptomatology that the patient has is good enough. And by way of investigations, you want to do a conjunctival swab, microscopy, and then culture and sensitivity. So that's conjunctival swab for routine examination and CS. And that should be able to give you the offending organisms and the bacteria that they are sensitive to. And by way of empiric treatment, we give broad spectrum topical antibiotics. All right, so chloramphenicol eye drops, gentamicin eye drops, ciprofloxacin eye drops, and tetracycline ointment. These are some of the most common and readily available antibiotics that we can use to treat bacterial conjunctivitis. Now we move on to the viral conjunctivitis, which arguably might be the most common type of conjunctivitis that we might come across. We'll look at 4 main types. We have what we call the epidemic keratoconjunctivitis, which is usually caused by the adenovirus types 8 and 19. Then we have the pharyngoconjunctival fever. This is caused by adenoviruses types 3, 4, 7, and occasionally 5. Then we have the acute hemorrhagic conjunctivitis, which is caused by enterovirus 17. Then other causes are herpes simplex virus, molluscum contagiosum, and the rest. Now, the epidemic keratoconjunctivitis is what we commonly refer to as Apollo. There comes a time when you say Apollo, having redness of the eye. Apollo. So that is Apollo for you. Now, the pharyngoconjunctival ones, typically the person will present with a fever, a sore throat. So you are looking at more of an upper respiratory tract infection. Then you realize that the person also has conjunctivitis. And the offending organism in this case is adenovirus type 3, 4, and 7. All right, so what are some of the symptoms that you see? Person will come in with redness of the eye. There will be a watery discharge. There's a sensation of sand on the eye. That's the grittiness. And typically, the person might tell you that there are people in his vicinity or people around you who also have a red eye. So people are having red eye. This person also has red eye, which gives us the epidemic nature of this conjunctivitis, which we call Apollo in our local dialect. And of course, if it's the the pharyngoconjunctival fever. Person might also have symptoms of an upper respiratory tract infection. So what are some of the signs that you see? So here also, you'll see injection or subconjunctival hemorrhages, which are responsible for the redness of the eye. And then there's watery discharge. And you can see in this picture here, you see some small vesicular looking structures. This is a bit exaggerated, okay, but just for you to get what it is. But you see some small, what do you call it? Small vesicular-like structures under the eyelid. Okay, and these are the follicles. All right. And sometimes you might have what looks like extra membranes appearing on the eye, but they are not true membranes in that they don't have the microscopic structures of a membrane. All right. Now, you may or may not have regional lymphadenopathy. And I'm sure if you remember the lymph drainage of the eye as we discussed the anatomy, you'd expect to see these lymph nodes at the preauricular areas and also the submandibular regions, which are the areas where you have lymphatic drainage of the eye. So, as it is with most viral conditions, we don't necessarily give any specific treatment, but management is largely managing the symptoms and also supportive care, just because it's a self-limiting condition. So if someone gets Apollo and you don't do anything about it, it goes by itself, really. So that is one assurance you can give. But then to give us, caution here, when you're examining this person, note very well that because of the epidemic nature, you may also pick up the Apollo. So if you have to meet such a person, make sure you wash your hands. Make sure that if you touch anywhere close to the eye of the patient, you are wearing gloves, or make sure you wash your hands immediately after. Otherwise, you also catch the infection. All right, so when there's an outbreak, more or less we advise people on preventive measures, that is health education on the causes. You encourage hand washing and hygiene protocols such as using your own hanky, you're not touching things that belong to people. Typically in a class, someone with Apollo has started the eye many times, has held his pen, somebody lend me your pen, the person also scratches the eyes and so on, and then it keeps spreading like that. All right. Okay, so the allergic type of conjunctivitis. So as the name suggests, this is more of an allergy. The main types, you have the acute and the chronic, okay? Now the acute type is more of due to atopy or hay fever. When sometimes in the harmattan season, typically in Ghana, realize that there's more pollen and other minute pollens in the air, and when these fall on the eye, they end up being as conjunctivitis. Rarely, when someone is having an allergy to something, maybe a substance, a drug, or whatever, you may have the person presenting with acute conjunctivitis. Then the chronic is what we describe as venal keratoconjunctivitis. There are certain people who have a persistent or allergy to so many things. And certain people can have the venal keratoconjunctivitis. Sometimes there are some drugs that we give, like the sulfonamides, neomycin, and the rest, that can also cause conjunctivitis. And this type is usually associated with what do you call it? Allergic rhinitis. The person might be asthmatic, or the person might be having atopy or eczema. All right. So these are other features that you can pick up on the patient that can make you realize that the person is having allergic conjunctivitis. So typically, the atopic one, when you're taking the history, you'd have at the back of your mind that it's a dry period where pollens are more in the air, and a person might be someone who is frequently allergic to many things. All right, so that person might have an acute occurrence. The chronic type person might have maybe some photophobia, might have some tearing, burning, and this has been going on for long periods. So I don't know if you've seen some of these asthmatics or people who have a lot of allergies. Their eyes look so brown, as if they poured something on their eye. Okay, that's how the viral keratotic conjunctivitis will look like. And as I said, taking a history, you realize that the person might be having rhinitis in addition to the conjunctivitis. The person might be asthmatic or might be having some allergic skin conditions also. Okay, what is on my screen? What is on my screen? Did someone draw this? Can you see the line on my screen?
Yes.
What is it? Is my screen broken?
No, Doc, it's not your screen.
No.
Someone used a pen tool at the top. There's a
It was
menu
a
at the top there.
mistake.
I'm sure the person is not aware.
Hey, why people can do that? Am I safe?
Oh, sir, you are
They
safe.
are writing on my computer.
It's a design. It's a design flaw in the zoom up. Yeah.
You are safe, sir. Relax.
No cause for alarm.
Yes.
Okay. So this is the allergic conjunctivitis. So as the name, first conjunctivitis, of course, you expect there to be redness. And then there's eye discharge. The acute ones are usually watery, but then the chronic ones, like the venal type, or people with atopy, might have it being a bit more mucoid. And this, I think it should be easy for you to tell the difference between this mucoid discharge and one that is pus. You will note also that this one, even though you might be tempted to think this is pus, you realize that the eyelashes are very free. You don't have eye discharge forming any crust in it. I hope you can all appreciate that. All right.
Yeah.
Now, typically for allergic ones, the person might have itchy eyes. So is the person, as we saw, and also they also complain of having a sensation of foreign body of the eye. It causes them to keep rubbing the eyes. Okay. So basically, these are the injections or the papillae that we are seeing on the eye. Okay, so treatment. We are looking at health education. You want to teach people how to avoid these things. If people can identify things that they are allergic to, they avoid them, and that will help reduce the incidence of the condition that we have. Also, it is self-limiting. So if it's not that severe, you can reassure the patient to relax and let it be. However, sometimes you may have to give some topical drugs such as antihistamines, can give some vasoconstrictors or decongestants, muscle stabilizers, NSAIDs, and corticosteroids. A common one that we have is the oral antihistamine, that is cetirizine. You can give cetirizine in this condition. It works just as well, aside the topical one. But most of them, you might not see them readily around. The muscle stabilizers, the levocabastin, you can't find it commonly. So cetirizine works just as well in this regard. All right. Now we go to the more stubborn or the more severe form of conjunctivitis. Now, this conjunctivitis that is being caused by Chlamydial trachomatis. Chlamydia trachomatis. There are three types that we want to talk about clinically. That is neonatal Chlamydial conjunctivitis. And I'm sure you'd guess that this one is acquired during delivery. So that if the mother is infected, then as the child is being born through the genital tract, the child eye comes into contact with the secretions and so gets this eye infection. You can also have trachoma in children, and typically this is caused by serotypes A, B, A, and C. Now, in adults, this is usually from genital secretions. So the culprits here are serotypes D to K. Okay, so sexually active people touching secretions, touching their eyes, putting their faces where they shouldn't be, and all of that. Then they end up in the chlamydia conjunctivitis. Who are those laughing? Mention your name. Let me ask you a question. Young lady laughing. What's the name?
It's Ronald.
Ronald. Ronald.
Yeah, Ronald.
Ronald. How do you understand this point? That's Anyway, we'll leave you to your devices. Okay. So here also there's redness, there's discharge. As for conjunctivitis, the first thing you always talk, clinical feature you always mention is redness. So there's a discharge, which is micropollen, there are follicles, there are papillae also. And in children, they may be associated with otitis, maybe associated with rhinitis, pneumonitis. We have 10 minutes in. I think we should be able to finish. Okay, maybe we can finish. So treatment, health education. So here you are making sure that, what do you call it? You are educating people, especially our adults, on some of these things. I mean, genital tract infections should be quickly treated. And some of these health practices should also be avoided if you have to avoid this condition. By way of treatment, we can give topical and or systemic antibiotics. Tetracycline, doxycycline, erythromycin, azithromycin. These are the common drugs that we give. Tetracycline is a topical one. Doxycycline, erythromycin, and azithromycin are systemic ones that we take orally. Now, I want you to go and read about when it comes to trachoma, the acronym SAFE. Go and read about SAFE. Okay. We might have a discussion on it, or it might appear elsewhere. Okay. So chemical conjunctivitis. So this usually is occurring due to drugs. Typically when maybe have some chemicals or some drugs entering the eye. Also has almost the same features as injection, there's most swelling, the follicles are present. But a key thing that is going to help you here is the history. So treatment is basically prevention and supportive care. However, if it's severe, we have to refer the person to the ophthalmologist to have a look at. Okay. Now, this neonatal conjunctivitis, commonly known as Ophthalmia neonatorum. Ophthalmia neonatorum. It's typically caused by bacteria, viral, chlamydia, or chemical toxic. So basically what you're saying is that if you're having conjunctivitis within the first month of life, the name changes to Ophthalmia neonatorum. That is neonatal conjunctivitis. And the same etiological factor or agents still apply here. Okay. Typically or usually they are mother to child. So this is neonatal conjunctivitis, or Ophthalmia neonatorum. It has the same features. So because in children, their immune system is not as well developed, it can become a very serious infection, okay? And most of the time, they are getting it through, they are passing through the mother's birth canal. And sometimes due to unhygienic practices. Okay, so the same thing, red eyes, swollen eyelids. The thing, if you've ever seen ophthalmia neonatorum before, you realize that the discharge is very, very copious. Very, very copious. In fact, it can be scary. And it's pussy, and then it forms crust on the eye, and it sometimes even dries the eye shut, and the child will be unable to open the eyes. So management, you clean the discharge as much as you can. We give tetracycline ointment, not oral, please, ointment that is on the eye. Mother is taught how to apply them. And if it's severe, we would want to give inpatient management with tetrazone and cefotaxime, okay? And don't forget to treat the parents for STD, okay? All right, so by way of preventing ophthalmia neonatorum, immediately now it's a protocol everywhere where children are born, the eyes are quickly clean, and then they apply tetracycline eye ointment to prevent the occurrence of this condition, okay? And antenatally, we investigate and treat all sexually transmitted diseases that the mother might have. Okay. All right. So this is these are some differential diagnoses. We have corneal ulcer, we have iritis, we have, okay, so this is our condition conjunctivitis here. We can have subconjunctival hemorrhage and acute glaucoma. So all of these, we'll look at them. But just for you to have at the back of your mind that with all of these conditions, you can also have a red eye. And that is where the importance of the history, that is where the history comes in as very important. So I think I'll pause here. We have 4 minutes more. If there are any questions, I'll quickly take them. And then we can continue. I mean, you can.
Sir, good evening, sir.
Good evening.
My name is Nathaniel. Sir, I just want to know, with these infections, is it only STIs that can cause them, or there are other causes as well?
Hey, were you in from the beginning?
No, sir, I came in a bit late because and then my network went off. I just had network connection. That's why.
Okay, so we said these are the various causative agents. We have bacteria, we have viruses, we have chlamydia, we can have a chemical or toxic ones, and we also have allergens, all of which can cause the conjunctivitis.
Okay. Thank you, sir.
All right.
Sir, please consider some of us. I came me personally late, so we can.
The thing was from 6 o'clock. Is someone talking? I didn't hear you. Yes.
Hello, sir. Sir, good evening.
Good evening.
Sir, good evening.
Yes, evening. I'm listening.
Yes, sir, good evening. Can you hear me, please?
I can hear you.
Yeah, please, my question is on the TEM.
The what?
TEM.
I can
Yes,
hear you.
I have a patient who has suffered from it, and I didn't know the number of times he used the drug. Is it that you overused it, or He started a long time. Now he is gone blind.
Sorry, your line is breaking far. You say he has what?
TM has gone blind. So can you hear me?
I'm just hearing gone blind. I'm not hearing it.
Hello.
Yes. Yes.
Hello.
Yes, speak up. I can hear you.
Hello.
Yes, I can hear you. If your network is bad, you can type in the, is there
Yeah, he used the traditional eye medicine and now he's gone blind.
he's using traditional.
I don't know whether he overused it or he started long time without.
Can you come again? Traditional eye medicine. What do you mean by traditional eye medicine?
Yes.
What do you mean by traditional eye medicine?
Traditional medication.
Hello, Doc.
Yes.
We have less than a minute. Most likely, we will not get clarity before the minute will end. So maybe I can start another session specifically for questions' sake. Maybe we'll do a few minutes and then we can call it a night. That's fine.
Okay, then let's relog in. Let's take some 5 minutes questions and then.
All right, Doc. So guys, please, I'll start the session again. Thank you.